All right, imagine this. You're looking at a tiny heart structure flashing right before your eyes. A little piece of the aorta isn't quite complete, and then, get this, a vessel that should be going to the lungs is supplying the heart itself. Colors are swirling everywhere, showing just how wrong the blood flow is. Makes you a little uneasy, right? Well, that's exactly the kind of puzzle we're going to try to solve today. We've got these glimpses, these hints of diagnoses, and we're going to take all that complexity and try to make it make sense. It's like getting your own personal decoder ring for all these complicated heart problems.
Yeah, we've got this really interesting collection of diagnoses, all from real patients. We'll be looking at everything from brand new babies to young adults, and we're going to be using all sorts of tools to figure them out. Like we've got echocardiograms, those are like little movies of the heart, and we've got ECGs, which show the electrical activity of the heart. Oh, and we've got pressure and oxygen readings from cardiac catheterizations, and even chest x-rays and CT scans to give us the bigger picture.
It's like we're going on a guided tour of some of the most interesting challenges in pediatric and congenital cardiology. And don't worry, we're not going to just throw a bunch of facts at you. We're going to break down each case, figure out the key clues that help us diagnose these problems. By the end of this, you'll have a much better understanding of this amazing organ and what happens when things go wrong.
You know, before we jump into the cases, we really have to thank the folks over at London Heartbeat Z Academy in the UK. They've been amazingly supportive in helping us put together all of this information. Honestly, their courses are fantastic, and they have over 150 of them. You should definitely check them out. And if you want to stay up to date on all things cardiology, make sure you subscribe to their social media pages like Facebook, Instagram, and YouTube. You won't want to miss their future discussions, that's for sure.
All right, let's dive right in with case number 1. We've got a modified suprasternal long axis view from a newmate, a newborn. And the diagnosis is interrupted aortic arch type 2. So what does that actually mean? Well, think of the aorta as the main highway for blood leaving the heart and going to the rest of the body. In this condition, the highway has a gap in it. Type 2 means that the gap is located after the blood vessels that go to the head and arms have already branched off.
And that means that the lower part of the body totally depends on another route for blood flow. In newborns, that lifeline is usually the ductus arteriosus, or PDA. It's a little blood vessel that should close up soon after birth. But in babies with an interrupted aortic arch, it stays open. It's the only way oxygen-rich blood can get to the belly and legs.
Right, that makes sense. Which leads us right into case number 2, a parasternal short-axis view at the level of great vessels in a neonate. The echocardiogram shows us that the left coronary artery, which is one of the main vessels that supplies blood to the heart muscle, is coming from the pulmonary artery. It should be coming from the aorta. That's like connecting your car's fuel line to the exhaust pipe.
And that creates a serious problem for the heart muscle, right? The blood in the pulmonary artery has way less pressure and oxygen than the blood in the aorta. So the left ventricle, which is the heart's main pumping chamber, isn't getting the oxygen it needs. And when we look at the color flow mapping on the echo, it's very clear. We see reverse flow, shown as blue in the LAD, left anterior descending artery, and red in the circumflex artery. It means blood is moving away from the heart muscle toward the pulmonary artery. It's going the wrong way.
So the heart muscle is starving for oxygen. Now we've got another view, this time from a newborn with an interrupted aortic arch, just like our first case. And we're told that the baby is PDA dependent for systemic blood flow. We talked about the PDA before, right? That crucial little vessel. Well, the echo shows a large PDA. I'm not surprised, considering it's keeping this baby alive.
Right. And when we look at the color flow mapping across this PDA, we see something interesting. A bidirectional shunt. Blood's moving both ways through the PDA. So why is that a big deal?
Well, I think it tells us something about the pressure on either side of the PDA. And if we check the CW Doppler, which measures blood flow velocity, we can learn even more about this shunt. What we see is right-to-left flow during systole, that's when the heart contracts. But then we see left-to-right flow during diastole when the heart relaxes and fills up again. That specific pattern is a pretty strong indicator of low pulmonary vascular resistance.
Think of it this way. During systole, the pressure in the aorta, well, in what's left of the aorta, is higher than the pressure in the pulmonary artery. So blood flows from the aorta through the PDA to the lower body. But during diastole, things change. The resistance in the lungs is low, so some of the oxygen-rich blood in the pulmonary artery shunts back into the aorta through the PDA. It's this two-way flow, especially the right-to-left flow during systole, that keeps the blood flowing throughout the body, even with the interrupted aortic arch. And this low resistance in the lungs is pretty normal for babies, but that'll change as they grow.
Okay, so those first two cases really show us how important the PDA is, especially in babies with these really serious heart defects. It also makes it clear that the heart needs oxygen-rich blood from the right source. If a main coronary artery comes from the pulmonary artery instead of the aorta, that's a huge problem.
Absolutely. Now let's switch gears a bit and talk about a different tool. A transesophageal echocardiogram, or TE. It's basically an ultrasound probe that goes down the esophagus. It gives us a really clear view of the heart from behind. This particular T shows a flagellar mass attached to the atrial surface of the anterior leaflet of the mitral valve. That flagellar mass sounds like something that's moving around.
It does. So what could this mystery mass be?
Well, there are a few possibilities, but we can't say for sure just from the image. It could be a vegetation, which is basically a clump of bacteria and stuff that forms on a heart valve that usually happens with an infection like endocarditis. Or it could be a myxoma, which is a type of benign tumor that can grow in the heart. They're usually in the left atrium attached to the wall between the atria, but sometimes they grow with mitral valve. And lastly, it could be a thrombus, a blood clot.
So even with this picture, we can't really tell what it is.
Not definitively, no. The way it looks, its size, how it moves those things can give us some clues, but to really know for sure, we need to look at the patient's whole situation. Do they have a fever? Have they had blood clots before? We might need more tests like blood cultures or imaging with contrast to figure out what it is. The T gives us a good visual, but it's just one piece of the puzzle.
Okay, makes sense. Let's move on. We've got an apical four-chamber view next. This is a standard view in echocardiography. It's like a head-on view of all four chambers of the heart, both atria, both ventricles, and the valves between them. In this one, we see a dilated left atrium. That means the upper left chamber is bigger than it should be. And there's a shelf above the mitral valve. Shelf makes it sound like something's blocking the way.
You could say that, and the color flow mapping confirms it. There's turbulence in mitral inflow starting above the mitral valve. That turbulence means the blood is hitting a narrow spot or something irregular that's messing with the flow.
So the left atrium is enlarged and blood is having a hard time getting through the mitral valve because of the shelf. And the diagnosis is a supramitral ring. So what exactly is that?
A supramitral ring is a heart defect that's present from birth. There's this membrane or sometimes a ridge of tissue above the mitral valve, like an extra layer or a narrowing, just above the valve. And this ring can obstruct the flow of oxygen-rich blood going from the left atrium to the left ventricle. Over time, that blockage forces the left atrium to work harder to push the blood through, which makes it get bigger. And the turbulence we see on the color Doppler, that's the blood trying to squeeze past that ring. The shelf you saw on the 2D echo is just what this abnormal tissue looks like.
So that connects what we see in the images to the actual problem. All right, our next case takes us back to a T. This one shows a ruptured aneurysm of sinus of Valsalva, non-coronary sinus, to ventricular septum. That sounds pretty bad. Aren't the sinuses of Valsalva those little pouches near the aortic valve?
Yeah, exactly. There are three of them. They're like little bulges in the wall of the aorta, just above the aortic valve leaflets. They help the aortic valve work properly. Now, an aneurysm means one of these sinuses has weakened and bulged out. If it ruptures, it can create this abnormal connection like a tunnel to another part of the heart. In this case, it's ruptured from the non-coronary sinus, which is one of the three, into the ventricular septum. That's the wall that separates the left and right ventricles. And because of this connection, blood from the aorta, where the pressure is high, can leak into the right side of the heart. That can overload the right side and lead to heart failure.
Okay, so our next image is a parasternal short-axis view showing an anomalous origin of right pulmonary artery from ascending aorta. Earlier, we saw a coronary artery coming from the wrong place, and now it's a pulmonary artery. It seems like there's a pattern here of blood vessels ending up where they don't belong.
Yeah, that's a good observation. It just shows how complex heart development can be. Normally, the pulmonary arteries, which carry blood that needs oxygen to the lungs, come from the main pulmonary artery, and that comes straight from the right ventricle. But in this case, the right pulmonary artery comes directly from the ascending aorta, which is where the oxygen-rich blood is going out to the body. It's going the wrong way. And that means the right lung might be getting way more blood than it should and at a higher pressure. That could cause pulmonary hypertension and other problems in the lung. The left lung, on the other hand, would be getting its blood flow normally from the main pulmonary artery.
Wow, okay. Our next diagnosis is ruptured sinus of Valsalva to right ventricle. It sounds similar to that aneurysm we talked about before, but this time the rupture goes right into the right ventricle, and the color flow mapping shows continuous flow from aorta to RV. That continuous flow sounds concerning.
It is. What that means is there's a constant leak of blood from the aorta into the right ventricle. Because the aorta has much higher pressure, the blood just keeps flowing through that hole. That puts extra stress on the right ventricle because it has to pump this extra blood. Over time, the right ventricle might get bigger and weaker, and eventually it could lead to heart failure.
All right, on to the next one. The diagnosis is large aortopulmonary window. So that sounds like there's a big opening between the aorta and the pulmonary artery when there shouldn't be any opening at all.
You got it. An aortopulmonary window is basically a direct connection between those two vessels. And when it's large, it means a lot of high-pressure, oxygen-rich blood from the aorta is going right into the pulmonary circulation, the blood vessels in the lungs. That's way too much blood going to the lungs, and it can cause problems. It can lead to pulmonary hypertension, which is high blood pressure in the lungs, and it can also put a lot of strain on the left ventricle because it's trying to pump blood to both the body and the lungs. If it's not treated, it can cause heart failure.
Okay. The next one is mitral regurgitation through isolated cleft in anterior mitral leaflet, TEE. So it looks like one of the flaps of the mitral valve isn't closing properly, and that's causing a leak.
Yep, that's exactly what's happening. The mitral valve, which is between the left atrium and left ventricle, has two leaflets that should close tightly to prevent blood from flowing back into the left atrium. A cleft is like a split or a gap in one of those leaflets. When the ventricle contracts, some of the blood, instead of going out to the aorta, goes back up into the left atrium through this cleft. That's the mitral regurgitation.
All right, the next one is about an abnormality of aortic valve. It's a quadricuspid aortic valve. So instead of having the normal 3 leaflets, this valve has 4. That sounds pretty unusual, but it's not necessarily a bad thing, right?
You're right, some people have a quadricuspid aortic valve and never have any problems, but a lot of times it can lead to aortic regurgitation, or AR. The problem is that the extra leaflet can mess up the valve's ability to close properly. So when the heart relaxes, some blood leaks back from the aorta into the left ventricle, and that leak puts more and more stress on the left ventricle over time.
So now we're getting into ECGs, which tell us about the electrical activity of the heart. This first ECG is from a child with dextrocardia. Just to clarify for our listeners, what exactly is dextrocardia?
Dextrocardia just means the heart is on the right side of the chest instead of the left. It's often associated with situs inversus, where all the organs are mirrored, flipped around, and you can see this flip in the ECG. The P wave, which normally goes up in certain leads because of the electrical activity in the atria, is actually going down in leads AVL and I, but it's positive in AVR, 2, 3, and AVF. The flip-flop of the P wave is a classic sign that the heart's electrical axis is reversed because the heart's on the right side.
And what about the QRS complex? That's the part of the ECG that shows the ventricles contracting.
Yeah, in dextrocardia, the QRS voltages in the chest leads, V1 to V6, are also reversed. Normally, as you move from V1 to V6, the QRS voltage gets bigger because you're getting closer to the left ventricle. But in dextrocardia, the voltage actually decreases as you move from V1 to V6 because those leads are getting farther away from the main action.
Fascinating. Okay, now we have a 1-day-old baby referred with diagnosis of bradycardia, a slow heart rate, and the ECG shows complete AV dissociation. So what does that tell us about the electrical communication in this little heart? And is there a connection to the mother's health?
Complete AV dissociation means the electrical signals from the atria, the top chambers of the heart, aren't getting through to the ventricles, the pumping chambers. So the atria and ventricles are basically beating independently, each at their own rate. In a newborn with such a slow heart rate because of complete AV dissociation, it's almost certain they have congenital heart block. This means they were born with this electrical problem. And one thing that's often linked to congenital heart block is if the mother has systemic lupus erythematosus, or SLE. If a mother has SLE, certain antibodies can cross the placenta during pregnancy and affect the baby's developing heart, sometimes causing congenital heart block.
So next up, we have a 20-year-old patient with clinical findings of ASD and atrial septal defect. Can we be more specific about what type of defect it might be just by looking at the ECG?
Let's take a look. The ECG shows sinus rhythm, which is a normal heart rhythm, and a normal P wave axis. That means the electrical activity in the atria is normal. But there's a prolonged PR interval, 0.22 sec. That means the signal is taking a little longer to get from the atria to the ventricles. We also see a QRS axis in left upper quadrant, minus 45 degrees. That means the electrical activity in the ventricles is shifted upwards and to the left. And finally, there's an incomplete RBBB, an incomplete right bundle branch block, which means there's a delay in how the right ventricle activates. When we see these three things together, it's a very specific pattern. It points toward an AV canal defect, which is also called an atrioventricular septal defect. This is more complex than a simple ASD. It's not just a hole between the atria, it often involves problems in the middle of the heart, where the atria and ventricles meet, including the valves.
So we thought it was a simple ASD, but the ECG is showing us it's more complicated than that. All right, the next case is a 6-month-old infant with CHF and mild cyanosis. That's congestive heart failure and bluish skin because of low oxygen. Their ECG shows sinus tachycardia, HR 140 minute, normal P wave axis, RA enlargement, tall P wave in lead 2, 3, AVF, left axis deviation, QRS axis minus 45 degrees, absence of RV forces, so not much electrical activity from the right ventricle, and LVH, chest leads and half voltages, meaning the left ventricle is enlarged. That's a lot of information. What could be causing all of this?
This ECG is telling us that there's a problem with the balance of the heart. The left side is much bigger and working much harder than the right side. There are a few things that could be going on here. It could be an AV septal defect, but one where the blood flow is mostly going to the left ventricle. Or it could be a hypoplastic right ventricle, which means the right ventricle is underdeveloped. We also have to consider tricuspid atresia without pulmonary stenosis. That means the valve between the right atrium and right ventricle is missing, and there's no narrowing of the valve leading to the lungs. And then there's single ventricle, where the heart is basically functioning with only one ventricle. All of these possibilities would explain the enlarged right atrium, the left axis deviation, and the enlarged left ventricle, especially if the right ventricle is tiny or not working properly.
Okay, our next patient is a 25 years old lady with exertional dyspnea, meaning she gets short of breath easily. She also has a subaortic membrane, a narrowing below the aortic valve, and critical aortic stenosis, severe narrowing of the aortic valve. Her ECG shows sinus rhythm, normal P wave axis, QRS axis plus 40 degrees, LVH, inverted T wave in V4, V5, V6. So how does her ECG connect with her heart problems?
Her ECG is basically showing us that her left ventricle is working way too hard because of the blockage below and at the aortic valve. That's why we see LVH, left ventricular hypertrophy. The muscle has gotten bigger because it's constantly straining. Those inverted T waves in V4, V5, and V6 tell us that there are some problems with how the electrical signals are traveling through the heart. That can happen when the heart muscle isn't getting enough oxygen. At least her upper chambers are working fine. That's what the normal sinus rhythm and P wave axis tell us.
Next, we have a 10-year-old child with cyanosis, no CHF. Their ECG shows sinus arrhythmia, long lead 2, normal P wave axis, extreme right axis deviation, frontal QRS axis plus 220 degrees, clockwise loop, right ventricle hypertrophy. So thinking about a child with cyanosis but no heart failure, what are some congenital heart defects that could cause these ECG findings?
Well, the cyanosis without heart failure, plus that extreme right axis deviation and right ventricular hypertrophy, tells us there's something blocking the blood flow from the right ventricle to the lungs. That blockage makes the pressure in the right ventricle go way up, and some of the deoxygenated blood ends up going to the body, causing cyanosis. There are a few possibilities. It could be D or V with pulmonary stenosis, where both the aorta and pulmonary artery come from the right ventricle. Or it could be DTGA, detransposition of the great arteries, with VSD and pulmonary stenosis. And of course, we have to consider tetralogy of Fallot. That extreme right axis deviation makes tetralogy of Fallot pretty high on the list, especially since it usually has a VSD, overriding aorta, pulmonary stenosis, and right ventricular hypertrophy.
Now we've got an 11-year-old child with cyanosis, no CHF. This one's got a HR 60-minute complete AV dissociation, absence of Q wave and left-sided leads, right axis deviation, frontal QRS plus 110 degrees, biventricular hypertrophy. What's the most likely diagnosis in this case?
Complete AV dissociation with a slow heart rate in a child who has cyanosis but no heart failure, plus the right axis deviation and both ventricles being enlarged. That really points to corrected transposition of the great vessels with VSD and PS, ventricular septal defect, and pulmonary stenosis. It's also called LTGA. Basically, the aorta and pulmonary artery are switched, and the ventricles are flipped too. But this kind of setup often messes with the electrical system of the heart and can lead to complete heart block. That explains the AV dissociation and slow heart rate. The VSD allows blood to mix, which is why the child has cyanosis, and the pulmonary stenosis makes the right ventricle work harder, which is why both ventricles are enlarged. The missing Q waves in the left-sided leads are also something we see with corrected transposition because the ventricles are activated differently.
This next ECG is from a 3-month-old child referred with diagnosis of dilated cardiomyopathy. That means the heart muscle is weak and stretched out, but their ECG is a little strange. It shows sinus tachycardia, HR 130 minute, normal P wave axis, left axis deviation, frontal QRS axis plus 20 degrees, LVH by voltage, deep Q wave in lead eye, AVL V5, V6. Could these specific ECG findings mean something else is going on besides just dilated cardiomyopathy?
Yeah, those deep Q waves in the lateral leads, those are the ones on the left side, are really important, especially in a baby this young who also has signs of left ventricular hypertrophy. This makes us think about something called anomalous origin of the left coronary artery from the pulmonary artery. It's sometimes called L's kappa. Basically, the left coronary artery, which should be getting oxygen-rich blood from the aorta, is mistakenly connected to the pulmonary artery, where the blood has low pressure and low oxygen. That means the heart muscle isn't getting enough oxygen, which can lead to a heart attack and eventually dilated cardiomyopathy. Those deep Q waves. Those are often a sign that a heart attack has already happened.
Okay, this next case is a 10-year-old child referred with cardiomegaly mild cyanosis. We also have ECG findings from a 14-year-old child with severe Epstein's anomaly of tricuspid valve, which is probably a similar condition. This ECG has a lot going on. Sinus rhythm, HR 100 minute, PR interval 0.20 sec, Paul P wave, Himalayan P wave RA enlargement, wide QRS complex, frontal QRS axis of plus 100 degrees. This really sounds like a distinct pattern.
It is. This is a classic ECG for Epstein's anomaly. The most obvious sign is that really tall P wave. It's called a Himalayan P wave because it looks like a mountain peak. That shows us just how much the right atrium is enlarged. The slightly long PR interval and that wide QRS complex, those could be because of abnormalities in the electrical system of the heart and the right axis deviation. Well, that makes sense because in Epstein's, the tricuspid valve is displaced, so part of the right ventricle actually acts like part of the right atrium. This leads to tricuspid regurgitation and a bigger right heart.
Okay, this next one is a little different. Instead of looking at a specific ECG, we're thinking about broader associations. We're asked to name 2 conditions in the setting of CHD, congenital heart disease that can lead to ventricular tachycardia. That's a really fast, dangerous heart rhythm that starts in the ventricles.
There are a lot of congenital heart defects that can increase the risk of ventricular tachycardia. It's often because of structural problems or scarring in the heart that mess with the electrical signals. 2 big examples are arrhythmogenic right ventricular dysplasia, sometimes called ARVD or ARVC. In this condition, the muscle in the right ventricle is slowly replaced by fat and scar tissue. That can make the heart electrically unstable and cause arrhythmias, like ventricular tachycardia. Another condition is Duval's anomaly, which is very rare. In Wells's anomaly, the right ventricle is super thin or sometimes even missing entirely. That kind of structural problem also makes the heart prone to dangerous arrhythmias. And we can't forget about people who have had surgery that involve cutting into a ventricle of ventriculotomy. That can cause scar tissue that increases the risk of ventricular tachycardia, especially after surgery for tetralogy of Fallot or to close a muscular VSD.
Okay, let's move on to hemodynamic data from cardiac catheterizations. This is where we get those precise measurements of pressure and oxygen levels right from inside the heart. Our first set of data is from a 7-day-old neonate with host cyanosis. We've got all sorts of readings from different parts of the heart. Based on all these numbers, what do you think is going on, and what kind of treatment would this baby need?
Well, the first thing we should look at is the oxygen saturation. The superior vena cava, or SVC, saturation is 52%, which is about what we'd expect for deoxygenated blood coming back from the upper body. But the aorta saturation is only 64%. That's much lower than the pulmonary vein PV saturation, which is 98%. That's oxygen-rich blood coming back from the lungs. This difference tells us that deoxygenated blood is mixing with the blood going out to the body. Now let's look at the pressures. The right ventricle pressure is higher than the pulmonary artery pressure, which means there's either a blockage or high resistance in the blood vessels going to the lungs. And the left atrial pressure is a bit higher than the right atrial pressure. The left ventricle pressure is lower than the aorta pressure. So we've got low oxygen in the blood going to the body, high pressure in the right ventricle compared to the pulmonary artery, and a pressure difference between the atria. All of this in a newborn who's blue. It's classic complete transposition of the great vessels, or TGA, with an intact interventricular septum and a restrictive atrial communication.
In TGA, the aortic comes from the right ventricle and the pulmonary artery comes from the left ventricle. You're switched. So the blood flow through the heart and lungs is totally messed up. The only place where oxygen-rich and oxygen-poor blood can mix is in the atria, and in this case, the opening between the atria is small, so there isn't much mixing. That's why the baby is blue. To treat this, they'd first do a balloon atrial septostomy, or BAS. That's a procedure to make the hole between the atria bigger so more blood can mix. And then, in the first few weeks of life, they do an arterial switch operation to fix the transposition and get those great vessels connected to the right ventricles.
Okay, our next set of data is from an 8 months old infant, OECHF cyanosis, congestive heart failure, and cyanosis again. What can we learn from these pressure and saturation numbers?
Okay, so here the SVC saturation is high, 84%. That can happen when there's a lot of mixing in the atria. The saturations in the right atrium, right ventricle, and pulmonary artery are all lower than the pulmonary vein saturation, so we know there's still deoxygenated blood in the right side of the heart. And the saturation in the aorta is low too. The pulmonary artery pressure is very high, which means there's pulmonary hypertension. The left atrial pressure is also a little bit high, and the right ventricular pressure is lower than the aortic pressure. So we have pretty low oxygen in the blood going to the body, even though the blood coming back from the lungs has plenty of oxygen. Plus, the pressure in pulmonary artery is really high, and the baby has congestive heart failure and cyanosis. This is highly suggestive of supracardiac total anomalous pulmonary venous connection, TAPVC, with restrictive atrial communication and pulmonary hypertension. In TAPVC, all the veins that should be going to the left atrium are connected to the wrong place. In this case, probably the superior vena cava or one of the veins that goes into it. So the oxygen-rich blood has to go through a small opening in the atrial septum to get to the rest of the body. That extra blood flow to the lungs causes pulmonary hypertension over time.
All right, next up we have an 8 years old child with mild cyanosis. Let's see what the pressures and saturations show us.
So the SVC saturation is low, and the saturations in the right atrium, right ventricle, and pulmonary artery are all pretty low too. But the saturation in the left atrium is great, almost 100%. Then it drops a bit in the left ventricle and stays low in the aorta. That means some deoxygenated blood is mixing with the oxygenated blood. The right ventricle pressure is super high, but the pulmonary artery pressure is low. The left ventricle pressure is normal. This pattern, with really high pressure in the right ventricle and low pressure in the pulmonary artery, along with low oxygen in the blood going to the body, even though the blood coming back from the lungs is good, it all points to severe pulmonary stenosis. There's a blockage where the blood leaves the right ventricle. And because the saturations in the right ventricle and pulmonary artery are about the same, it seems like there's a non-restricted VSD, a hole between the ventricles, which is allowing the blood to mix. So the overall diagnosis here is tetralogy of Fallot. The cyanosis is because some of the deoxygenated blood from the right ventricle is going through the VSD and into the left ventricle because of that high pressure from the pulmonary stenosis.
Okay, let's look at this next patient, a 5 years old child referred for bradycardia. What does their hemodynamic data show us?
The oxygen saturations here are a little tricky. The SVC saturation is low, and so are the right atrial and right ventricular saturations. But then, the pulmonary artery saturation is actually a bit higher. And then, the left atrial and aortic saturations are great, almost 100%. But the left ventricular saturation is lower. So what does that mean? Well, let's look at the pressures. The right ventricle pressure is very high, but the pulmonary artery pressure is low. And while the aorta pressure is normal, the left ventricle pressure is quite low. So we've got the pulmonary artery saturation higher than the right ventricle, high pressure in the right ventricle, low pressure in the pulmonary artery, and a mismatch between the aorta pressure and left ventricle pressure. All of this means the connections are all wrong. It's called AV and VA discordance. Basically, the atria are connected to the wrong ventricles, and the ventricles are connected to the wrong great arteries. This is what we see with congenitally corrected transposition of the great vessels, or LTGA. The right ventricle is doing the work of pumping blood to the body, which is why its pressure is so high. And the left ventricle is pumping blood to the lungs, which is why its pressure is lower. And like we talked about earlier, people with corrected transposition often develop complete heart block, which causes bradycardia.
Our next patient is a 24-year-old M who had a heart murmur when he was a child and is now having chest pain, trouble breathing, and signs of congestive heart failure and pulmonary hypertension. What does his hemodynamic data tell us? And what does that low SVC saturation of 56% mean?
Okay, let's see. The right atrial pressure is very high, and the right ventricle pressure is almost the same as the pulmonary artery pressure, which is high too. The left atrial pressure is also elevated, but the left ventricle and aorta pressures are pretty normal. Now, the oxygen saturations are interesting. The SVC saturation is very low, but then there's a jump in oxygen as the blood goes through the right heart, and then the saturations are great in the left heart and aorta. So what does this mean? Well, this sudden onset of symptoms, those high pressures in the right side of the heart and pulmonary artery, and that jump in oxygen saturation between the SVC and the right atrium, all point to a ruptured sinus of Valsalva aneurysm to the right atrium. That aneurysm in the aorta has burst and created a hole right into the right atrium. That explains why the oxygen saturation goes up. Blood from the aorta, which has lots of oxygen, is mixing with the blood in the right atrium, which has low oxygen. And that murmur he had as a child. Well, more than half of people with a ruptured sinus of Valsalva also have a restrictive VSD, so maybe that murmur was because of the VSD. Now, about that low SVC saturation, that means the body's tissues are taking more oxygen out of the blood than usual. That happens in heart failure, when the heart isn't pumping enough blood, so the body tries to compensate by extracting more oxygen from the blood that is circulating. As for treatment, usually they do surgery to repair the aneurysm. But sometimes, if the rupture is from the non-coronary sinus, they might be able to close it with a device. 2-year-old child who presented with mild cyanosis.
Cyanosis, that's the bluish tint to the skin, right?
Exactly. It indicates a lower than normal oxygen level in the blood. Not a good sign.
Definitely not.
Yeah.
So what else do we know about this little one?
We have some key findings from an echocardiogram, which is essentially an ultrasound of the heart.
Okay, an echo, what did that show?
Looking at a specific view called the apical 4-chamber view, which allows us to see all 4 chambers of the heart in one image, the doctors noted a dilated left atrium.
Dilated left atrium, meaning?
The left upper chamber of the heart was enlarged, bigger than it should be.
Got it. So the left atrium is too big. Anything else?
Yes, the 2D echo, a standard 2-dimensional ultrasound image, revealed something described as a shelf above the mitral valve.
A shelf. That's a strange way to put it.
It is, but it paints a pretty clear picture. The mitral valve is one of the heart's 4 valves. It sits between the left atrium and the left ventricle, controlling blood flow.
Right, right. I vaguely remember that from anatomy class.
So imagine a little ledge, a protrusion, sitting just above that valve.
A shelf. Okay, I get it. So we have an enlarged left atrium and this weird shelf-like thing. What about the blood flow in that area? Did the echo show anything unusual?
It did. Color flow mapping, which uses colors to visualize the direction and speed of blood flow on the echocardiogram, showed turbulence in the mitral inflow.
Turbulence, so the blood wasn't flowing smoothly.
Not at all. And the turbulence was observed starting above the mitral valve itself, right where that shelf-like structure was seen.
Interesting. Putting those pieces together, the enlarged left atrium, the shelf, the turbulent blood flow above the valve, what diagnosis are we looking at here?
Based on these findings, the diagnosis is a supramitral ring.
Supramitral ring, never heard of it.
It's a congenital heart defect.
Congenital meaning?
The child was born with it.
Ah, okay. So what exactly is a supramitral ring?
It's basically a membrane of fibrous tissue that partially obstructs the mitral valve.
So it's blocking the valve?
Partially. And this is the crucial part. The obstruction isn't at the valve itself. It's located just above the valve leaflets within the left atrium. That's why it's called supramitral, meaning above the mitral valve.
Okay, that makes sense. A ring, or in this case, a shelf, sitting above the valve and causing problems with blood flow.
Exactly.
Now, the information you shared also mentioned some pressure tracings.
Right.
And the first question is, what did those tracings indicate?
The pressure tracings showed suprasystemic right ventricular pressure.
Suprasystemic. I'm not familiar with that term.
Systemic pressure refers to the normal blood pressure in the main arteries of the body. So suprasystemic means the pressure in the right ventricle, the heart's lower right chamber, was significantly higher than that normal systemic pressure.
Wow, that sounds really high.
It is. And there's more.
Oh, no.
We also saw an inverted V tracing in the right ventricle.
Inverted V, is that bad?
It can be. This specific pattern on a pressure recording is a strong indicator of severe pulmonary stenosis.
Pulmonary stenosis, that's a narrowing of the pulmonary valve, right? The one that controls blood flow from the right ventricle to the lungs.
You got it. And this is often seen when the wall between the 2 lower heart chambers, the interventricular septum, is intact, meaning there's no hole between them. Or possibly if there's a very small ventricular septal defect, or VSD, which is a small opening between the ventricles.
Okay, so we have this obstruction on the left side with the supramitral wing affecting flow into the left ventricle. And then on top of that, a significant buildup of pressure on the right side because of this narrowed pulmonary valve.
That's the picture we're seeing.
And the second question is about the mild cyanosis. Why was this child slightly blue?
The cyanosis, that bluish discoloration, is a sign that not enough oxygen is reaching the tissues.
Right.
In this case, it's likely due to a couple of things, both related to the pressure differences we've just discussed.
Okay, I'm all ears.
Firstly, the high pressure in the right atrium, which is a consequence of the severe pulmonary stenosis, can lead to a right-to-left shunt at the atrial level.
Hold on, shunt.
A shunt is an abnormal flow of blood, in this case from the right side of the heart to the left. If the child has a patent foramen ovale, or PFO, that's a normal opening between the two upper heart chambers, the atria, that usually closes shortly after birth. Or even a small atrial septal defect, or ASD, which is an actual hole between the atria, the elevated pressure on the right side can force deoxygenated blood from the right atrium across this opening into the left atrium. This deoxygenated blood then mixes with the oxygenated blood returning from the lungs, and this mixture with a lower oxygen content is then pumped out to the body, causing cyanosis.
So basically, blood is bypassing the lungs because the pressure on the right side is too high.
You got it.
And you said there's a second possible reason for the cyanosis?
Yes. It's linked to the possibility of a small VSD, a small hole between the ventricles. If there is such an opening, the suprasystemic pressure in the right ventricle could also force some deoxygenated blood from the right ventricle directly into the left ventricle. This deoxygenated blood would then mix with the oxygenated blood and be pumped out to the body, further contributing to the cyanosis.
So we have two potential shunts contributing to the cyanosis, one at the atrial level and one at the ventricular level.
Precisely.
Fascinating how these seemingly separate findings are actually interconnected. Okay, let's move on to our next case. What have you got for us this time?
In this case, we're focusing on pressure tracing findings.
Pressure tracings. Got it. What are we seeing?
We see a wide aortic pulse pressure, specifically recorded as 140 millimillimeter G50.
Pulse pressure. Remind me what that is again.
Pulse pressure is the difference between the systolic pressure, the highest pressure when the heart contracts, and the diastolic pressure, the lowest pressure when the heart relaxes. A wide pulse pressure indicates a significant difference between these two readings.
Okay, a wide pulse pressure. What else is going on?
We also have an elevated left ventricular end diastolic pressure, or LVEDP, which is quite high at 40 millimillimeter G. LVEDP is the pressure in the left ventricle at the very end of its filling phase, just before it contracts again.
Right, so a big difference between the high and low pressures in the aorta and a higher than normal pressure in the left ventricle just before it pumps. What does that tell us?
These findings strongly suggest chronic aortic regurgitation.
Aortic regurgitation, what is that exactly?
It's a condition where the aortic valve, the valve that separates the left ventricle from the aorta, the main artery carrying oxygenated blood to the body, doesn't close properly.
So it's leaky.
In a way, yes. This allows blood to leak backward from the aorta into the left ventricle during diastole, the relaxation phase of the heart.
I see. So the blood is flowing in the wrong direction.
Exactly.
How does that explain the wide pulse pressure and the high LVEDP?
The wide pulse pressure occurs because the left ventricle has to pump out a larger volume of blood with each beat to compensate for this backflow. This leads to a high systolic pressure as the ventricle works harder, while the diastolic pressure drops because some of the blood that was just ejected into the aorta leaks back into the ventricle.
So the heart is working overtime to keep up.
It is. And the elevated LVEDP reflects the increased volume load in the left ventricle. It's having to accommodate blood returning from the lungs as well as the blood that's leaking back from the aorta.
The poor left ventricle. It's getting hit from both sides.
That's one way to put it.
Now, this case also asks us to name 3 conditions where we might see this kind of pressure pattern. We've already talked about chronic aortic regurgitation. What about the other 2?
Well, the source material primarily focuses on chronic aortic regurgitation in this case, given those specific pressure findings. It doesn't explicitly list 3 other conditions that would present with this exact same combination of findings.
Okay, so it's highlighting aortic regurgitation as the most likely culprit.
Right. But it's worth noting that other conditions that cause a significant increase in the volume of blood within the left ventricle could potentially lead to similar changes, though maybe not identical, in pulse pressure in LVEDP.
Makes sense. So it's not a hard and fast rule. But chronic aortic regurgitation is the prime suspect here.
Exactly.
Okay, let's move on to the next case. What's up next?
This case focuses on a very specific pressure tracing characteristic.
Lay it on me.
The key finding is a rise in right atrial pressure during inspiration.
During inspiration, meaning when someone breathes in.
Precisely. It's a very specific hemodynamic sign. Hemodynamic refers to the forces involved in blood circulation.
Right, of course. So a rise in right atrial pressure when breathing in. The information we have says that this is found in 3 particular conditions. What are they?
The source lists constrictive pericarditis, restrictive cardiomyopathy, and tricuspid stenosis.
3 big words.
They are, but don't worry, we'll break them down.
Please do. Starting with constrictive pericarditis, what's going on there?
In constrictive pericarditis, the pericardium, which is the thin sac that surrounds the heart, becomes thickened, scarred, and stiff. This stiffening restricts the heart's ability to expand fully, especially during diastole, the relaxation and filling phase.
So the heart is basically trapped in a stiff, unyielding sac.
Exactly.
Yes.
Now, when a person inspires, the pressure within the chest cavity, the intrathoracic pressure, decreases. This normal drop in pressure usually helps to increase the return of blood from the body to the right side of the heart. However, in constrictive pericarditis, the rigid pericardium limits the right ventricle's ability to accommodate this increased volume of blood. Because the ventricle can't expand as much as it normally would, the pressure backs up into the right atrium, causing a rise in its pressure during inspiration.
So the stiff pericardium is preventing the right ventricle from expanding properly, and that extra blood during inspiration is causing the pressure in the right atrium to rise.
Exactly.
Okay, that makes sense. What about restrictive cardiomyopathy? What's going on in that condition?
In restrictive cardiomyopathy, it's the heart muscle itself, the myocardium, that becomes stiff and doesn't relax properly during diastole. So even though the pericardium might be normal, the ventricles, particularly the right ventricle in this context, can't fill adequately.
So it's not the outer sac that's the problem, it's the heart muscle itself.
Right. And similar to constrictive pericarditis, when inspiration increases venous return to the right heart, the already stiff right ventricle can't accommodate the extra volume efficiently, leading to an exaggerated rise in pressure in the right atrium.
Same end result, different cause. Got it. And lastly, tricuspid stenosis. What can you tell us about that?
Tricuspid stenosis is a narrowing of the tricuspid valve, which is located between the right atrium and the right ventricle, and it controls the flow of blood from the upper right chamber to the lower right chamber. This narrowing, or stenosis, obstructs the flow of blood across the valve.
So the blood is having a hard time getting through the valve?
Yes. And during inspiration, as more blood returns to the right atrium, the pressure in the right atrium is already elevated because of the difficulty in pushing blood through the narrowed tricuspid valve. The increased venous return during inspiration further adds to the volume in the right atrium. And because the stenotic valve presents a bottleneck, this leads to a further increase in right atrial pressure.
Okay, so in all 3 of these conditions, we have a situation where the right ventricle's ability to handle the increased blood flow during inspiration is compromised, either by a stiff pericardium, a stiff heart muscle, or a narrowed valve. And this all manifests as that rise in right atrial pressure when breathing in.
Exactly. Different underlying issues, same hemodynamic finding.
It's amazing how the body works, isn't it? Okay, ready for the next case.
Always.
This one involves a child with aortic stenosis.
Ah, yes, aortic stenosis. We talked about that earlier. It's a narrowing of the aortic valve.
Right, the main outflow valve of the left ventricle. Now, in this case, they used a special procedure called a pullback catheterization.
Yes, pullback catheterization.
Right.
It's a valuable diagnostic tool.
So what happens during this procedure?
A thin, flexible tube, called a catheter, is advanced in a retrograde fashion, meaning against the normal flow of blood. It's guided from the left ventricle, across the narrowed aortic valve, and into the ascending aorta, the first part of the aorta.
Okay, so they're threading a catheter through the heart against the flow of blood.
Precisely.
And the source material says something interesting happens during the withdrawal, the pulling back of the catheter.
It does. During the slow withdrawal of the tip of the catheter from the high-pressure left ventricle back across the narrowed aortic valve and into the lower-pressure ascending aorta, the peak systolic femoral artery pressure, that's the highest pressure measured in the main artery in the thigh during the heart's contraction, increased by approximately 20 millimeter of Hg.
Wow, so the pressure in an artery in the leg actually went up as they pulled the catheter back. That's pretty counterintuitive.
It is, and this phenomenon has a specific name associated with it.
Which is?
Carabello's sign.
Carabello's sign. Okay, I'll try to remember that one. So what's the significance of this sign in a patient who has aortic stenosis?
Carabello's sign is a strong indicator of the severity of aortic valve obstruction. According to the source, this sign is typically seen only in patients who have a relatively small aortic valve area, specifically less than 0.6 square centimeters.
So a small valve area means severe stenosis.
Exactly. The reason we see this increase in peripheral systolic pressure during the pullback likely relates to the sudden release of the obstruction as the catheter tip moves from the high-pressure environment of the left ventricle through the narrow opening of the aortic valve and into the larger, less obstructed space of the aorta. This sudden ease in the flow of blood can lead to a reflex increase in the systemic blood pressure.
So pulling the catheter back is like suddenly opening a dam, and that causes a surge in pressure that's even felt all the way down in the leg.
That's a good analogy.
So basically, this seemingly localized maneuver with the catheter tells us something really important about the overall severity of the valve problem. That's pretty neat. Okay, on to the next case.
Our fifth case describes a 6-year-old child presenting with cyanosis.
Cyanosis again. Okay, what else do we know?
We have some key pressure measurements from inside the child's heart and arteries. The right ventricular pressure and the aortic pressure are reported as being equal, and the pulmonary artery pressures are noted as being within the normal range. Okay, let me get this straight. The pressure in the right ventricle is the same as the pressure in the aorta. Exactly. And the pressure in the pulmonary artery is normal.
And this child is cyanotic. This is a tough one. What diagnosis comes to mind?
The diagnosis in this case is a ventricular septal defect, or VSD, with pulmonic stenosis physiology, often abbreviated as PS physiology.
VSD with PS physiology. So there's a hole between the ventricles and something's going on with the pulmonary valve, even if it's not severely narrowed.
Right. The presence of some degree of pulmonic stenosis is crucial to understanding this case.
Okay, let's break this down. How do these pressure findings relate to the diagnosis and explain the cyanosis?
The fact that the right ventricular pressure and the aortic pressure are equal strongly suggests a large unrestricted ventricular septal defect.
So the hole between the ventricles is pretty big.
It is. If the hole is substantial, it allows for free communication of pressure between the left and right ventricles during systole, the contraction phase of the heart when they're both pumping.
Okay, so the pressure's equalized because the blood can flow freely through the hole.
Got it. Now, even though the pulmonary artery pressures are normal, the presence of pulmonic stenosis, even if it's not severe, is vital. It restricts the amount of blood that can flow from the right ventricle to the lungs to get oxygenated. If this restriction is significant enough, it can cause a net flow of deoxygenated blood from the right ventricle across the VSD into the left ventricle, where it mixes with oxygenated blood and is then pumped out to the body. This right-to-left shunting is what leads to the cyanosis.
Right, because the deoxygenated blood is sneaking across that big hole and mixing with the good blood.
Exactly. And the normal pulmonary artery pressure suggests that while there is some degree of narrowing at the pulmonary valve, it's not so severe as to cause significant pressure buildup beyond the valve in the pulmonary arteries themselves. It's a delicate balance between the size of the VSD and the degree of pulmonic stenosis that ultimately determines the level of oxygen in the systemic circulation.
So it's not just about a huge pressure difference on the right side, but rather the combination of that unrestricted hole and a partial blockage to the lungs that forces deoxygenated blood into the systemic circulation. Got it. Okay, ready for case number 6.
Bring it on.
Okay, this one involves a medical intervention.
Oh, interesting. Which one?
It describes a right ventricle to pulmonary artery catheterization that was performed after a balloon pulmonary valvotomy.
A balloon pulmonary valvotomy.
Yeah.
That's a procedure used to try and widen a narrowed pulmonary valve.
How's that work?
They guide a catheter with a deflated balloon at its tip to the valve. Then they inflate the balloon to stretch and open the valve leaflets, improving blood flow to the lungs.
So they're basically using a balloon to force the valve open. Clever. What were the hemodynamic findings after the procedure?
The findings show that the right ventricular pressure was still moderately elevated, with an RV systolic pressure of 84 mmHg. The aortic pressure was recorded as 100, 200, 365 mmHg, which is within a normal range. Importantly, there was still a significant pressure gradient of 55 mmHg across the pulmonary valve.
Pressure gradient. You mentioned that earlier.
Right, a gradient is the difference in pressure between 2 points. In this case, it's the difference in pressure as blood is squeezed through the pulmonary valve.
Got it. So the procedure seems to have had some effect, but there's still a noticeable obstruction there.
That's the takeaway. While balloon valvotomy often successfully reduces the pressure difference, it doesn't always eliminate it completely. An RV systolic pressure of 84 mmHg in the context of a systemic systolic pressure of 123 millimilli Hg, suggests that the pulmonary stenosis is now likely in the moderate range of severity.
So they didn't get rid of the stenosis entirely, but it's better than it was before.
That's the idea.
Okay, let's move on to our next case. This one seems a bit more complex. It involves a withdrawal tracing in a 50-year-old woman with a subaortic membrane.
Subaortic membrane. That's a congenital condition where there's a thin layer of fibrous tissue forming an obstruction in the left ventricle, just below the aortic valve itself.
Ah, so it's another type of blockage. But this time it's below the valve, not above it.
Correct. And what's interesting in this case is the pattern they saw on the pressure tracing as the catheter was withdrawn.
Okay, tell me about it.
The tracing showed a rather peculiar pattern. The systolic pressure in the subvalvular chamber, that's the area in the left ventricle just below the aortic valve where the membrane is situated, was equal to the systolic pressure in the aorta. However, the diastolic pressure in the same subvalvular chamber was equal to the diastolic pressure in the rest of the left ventricle.
Hold on, let me try to visualize this. So the pressure when the heart contracts is the same above and below the membrane, but the pressure when the heart relaxes is different.
Precisely. And there's another crucial detail. The tracing also revealed an absence of any pressure gradient at the level of the aortic valve itself. This means that as the catheter passed across the aortic valve, there wasn't a significant drop in pressure.
So the valve itself isn't really causing any obstruction.
It seems that way. Additionally, the LVEDP, the pressure in the left ventricle at the end of its filling phase, was elevated at 40 millimillim Hg.
So we have equal systolic pressures across the membrane, no pressure drop at the valve, and high pressure in the left ventricle at the end of filling. What do we call this?
This phenomenon is known as Brockenbrough's sign.
Brockenbrough's sign. Okay. And it's usually seen in patients with what?
It's classically described in the context of hypertrophic obstructive cardiomyopathy, or HOCM, a condition where the heart muscle thickens and can obstruct blood flow, particularly during exercise. However, the same principle can also be observed in patients with a fixed subaortic membrane, like in this case.
So it's not exclusive to HOCM, but it can be a feature of it.
Exactly.
And what causes Brockenbrough's sign? What's the underlying mechanism?
The key here is the role of a post-premature ventricular contraction, or PVC, compensatory pause. A PVC is an extra early heartbeat that disrupts the normal rhythm. Following a PDC, there's typically a longer than usual pause before the next normal beat occurs. This longer diastolic filling period allows more blood to fill the left ventricle, leading to an increased preload, which is the degree to which the left ventricular muscle fibers are stretched at the end of diastole.
Okay, so the heart gets a longer time to fill up with blood after a PVC.
Right. And according to the Frank-Starling law of the heart, the more the heart muscle is stretched within physiological limits, the more forcefully it will contract. In patients with dynamic outflow tract obstruction, whether it's due to a subaortic membrane or the thickened septum in HOCM, this increased contractility after a PVC can paradoxically worsen the obstruction during the very next beat.
So a stronger contraction can actually make the blockage worse.
It can, but Brockenbrough's sign specifically refers to the observation that the very first beat immediately following this compensatory pause often shows a decrease in the systolic pressure gradient across the obstruction, even though subsequent beats might show an increased gradient due to the enhanced contractility.
Wait, so the pressure gradient actually decreases at first? That seems counterintuitive.
It does. The equal systolic pressure seen here, with no pressure difference at the aortic valve itself, likely reflects a snapshot of the pressure tracing taken immediately after such a compensatory pause, where the dynamic obstruction caused by the subaortic membrane is momentarily less pronounced. The elevated LVEDP suggests an underlying issue with the left ventricle's ability to relax and fill properly, which can be seen in both subaortic membrane and HOCM. So the key takeaway is that the obstruction responds paradoxically to increased contractility immediately following a PVC, and that's a hallmark of dynamic outflow tract issues.
Wow, that's a lot to unpack, but fascinating nonetheless. Okay, ready for the next case. This one involves a 4-month-old infant with cyanosis and congestive heart failure, or CHF.
A young infant with CHF and cyanosis. That sounds serious.
It is, and we're given findings from a PA view of a chest x-ray.
Okay, what did the x-ray show?
The x-ray shows mild cardiomegaly, indicating a slightly enlarged heart. The shape of the heart is also noted. The ventricular apex, the bottom tip of the heart, is described as being an RV type, giving the overall cardiac silhouette a boot-shaped appearance.
A boot-shaped heart. That's interesting. What else?
There's a pulmonary bay.
Pulmonary bay. That refers to a noticeable concavity a flattening, in the region where the main pulmonary artery would normally appear as a rounded contour on the X-ray.
So it's like something is missing.
Exactly. Suggests it might be small or absent.
Makes sense. Anything else on the X-ray?
Finally, and perhaps most importantly, the radiograph shows a reticular pattern throughout the lung fields. This network-like appearance is highly suggestive of the presence of multiple collateral blood vessels.
Okay, putting it all together. A boot-shaped heart, that missing pulmonary artery contour, and all those extra blood vessels. In a young infant with cyanosis and heart failure, what diagnosis are we looking at?
The constellation of these findings points towards a diagnosis of ventricular septal defect, or VSD, with pulmonary atresia and multiple collaterals.
Pulmonary atresia, that's when the pulmonary valve is completely closed off, right?
Exactly. Blood can't get to the lungs through the normal route of the pulmonary artery.
That's a big problem.
Yeah.
How does this fit with what we're seeing on the X-ray?
With pulmonary atresia, there's no normal blood flow to the lungs. That's why we see cyanosis. The blood returning to the body hasn't been oxygenated. The VSD allows for some mixing of deoxygenated and oxygenated blood. The boot-shaped heart, with the apex formed by the right ventricle, is a sign of right ventricular hypertrophy. The muscle of the right ventricle has thickened because it's working very hard trying to pump blood against that closed pulmonary valve.
The heart is basically fighting a losing battle.
You could say that. And the pulmonary bay is present because the main pulmonary artery is either very small, hypoplastic, or completely absent atretic. And crucially, the reticular pattern we see in the lungs indicates the development of multiple aortopulmonary collateral arteries, or MAPCAs. These are alternative blood vessels that sprout and grow from the aorta to try and supply blood flow to the lungs when the normal pulmonary arteries are underdeveloped or absent. Finally, the CHF arises from the increased workload on the heart and the complex and often inefficient circulatory pathways created by the VSD in these collateral vessels.
So the body is trying to create detours to get blood to the lungs because the main road is closed. Incredible. It's like the circulatory system is saying, we're not giving up.
It's a remarkable adaptation, though ultimately insufficient in this case.
Okay, let's move on to our next case. It involves a newborn baby, just 5 days old.
A 5-day-old neonate. Okay, what are the presenting symptoms?
This little one presented with tachypnea, which is rapid breathing, and mild cyanosis.
Tachypnea and cyanosis in a newborn. Never a good sign. What about the chest x-ray?
The X-ray showed cardiomegaly, meaning the heart appeared larger than it should be for a baby of that age. It also revealed a narrow pedicle.
Narrow pedicle. In this context, that refers to the combined width of the great vessels, the aorta and pulmonary artery, as they emerge from the base of the heart. A narrow pedicle is a classic sign in certain heart conditions.
Okay, narrow pedicle. Got it.
The X-ray also demonstrated increased pulmonary blood flow, meaning there was more blood going to the lungs than normal, and this increased flow seemed to be preferentially directed towards the right lung.
So to recap, cardiomegaly, narrow pedicle, and increased blood flow to the lungs favoring one side. What's the diagnosis?
The diagnosis in this neonate is complete transposition of the great vessels with a non-restrictive ventricular septal defect.
Complete transposition. That's where the aorta and pulmonary artery are hooked up to the wrong ventricles, right?
Exactly. In complete transposition, the aorta, which normally carries oxygenated blood from the left ventricle to the body, arises from the right ventricle instead, carrying deoxygenated blood. Conversely, the pulmonary artery, which normally carries deoxygenated blood from the right ventricle to the lungs, arises from the left ventricle, carrying oxygenated blood back to the lungs.
So the blood flow is all mixed up?
You could say that. It creates two separate parallel circulations instead of the normal series circulation. For the baby to survive, there must be some way for the oxygenated and deoxygenated blood to mix.
And that's where the VSD comes in.
Exactly. The ventricular septal defect provides the route for mixing.
That makes sense. What about the other findings?
The cardiomegaly is a result of the increased volume load on both ventricles as they deal with this abnormal circulation. The narrow pedicle is due to the abnormal anterior-posterior relationship of the transposed aorta and pulmonary artery. And the increased pulmonary blood flow, often more pronounced to one lung, can occur because with a large non-restrictive VSD, the resistance to blood flow in the lungs may not be as high in the early newborn period as it would be later on.
So the VSD is actually a good thing in this case. We have a 5-day-old neonate who's experiencing tachypnea and mild cyanosis.
So rapid breathing and a bit of a bluish tint, indicating maybe some trouble with oxygen.
Yeah, and the chest x-ray, a PA view, showed cardiomegaly, so an enlarged heart, a narrow pedicle, and increased pulmonary blood flow, but with a preference for the right lung.
Interesting. So already we're seeing some signs that things might not be quite right.
And the source asks, what's the possible diagnosis here?
Well, without jumping to conclusions just yet, when you see an enlarged heart in a newborn, especially with a narrow pedicle, that can make you think about the position of those great vessels, the aorta and the pulmonary artery.
Right, and then you add in that uneven blood flow to the lungs, and it seems like we might be dealing with some kind of congenital heart issue.
Absolutely. The preferential flow to one lung over the other suggests that the plumbing of the heart, if you will, might be a bit off, and that can lead to problems with how the blood is oxygenated and circulated.
Makes sense. Okay, case number 2, we have a 10-week-old infant presenting with CHF, PAH, and bradycardia.
Wow. So congestive heart failure, pulmonary artery hypertension, and a slow heart rate. That's a lot going on.
Right. And the chest x-ray showed cardiomegaly again and increased pulmonary vascular markings. But here's where it gets interesting.
Yeah, what else did they find?
The report mentioned a high takeoff of the right pulmonary artery because of an absent aortic shadow in its usual location.
So the aorta isn't where it's supposed to be.
Exactly. And then on the left side, the aortic shadow was really prominent, almost like an L-posed aorta.
Okay, now that's a key finding, the L-opposed aorta. It's a classic sign that often points towards transposition of the great arteries.
Transposition meaning they're switched?
Yeah, basically the aorta and the pulmonary artery are coming out of the wrong ventricles of the heart.
Oh, wow. So that explains why the right pulmonary artery had that high takeoff.
Right, and all of this lines up with the clinical signs, the CHF, the PAH, the bradycardia. It all fits together.
It's amazing how one little detail, like that L-shaped shadow, can reveal so much.
It's like a puzzle piece. Once you see it, it all starts to make sense.
All right, case number 3, we've got an 18-month-old child with cyanosis, but no signs of CHF.
Okay, so that's a bit different from our previous cases.
Yeah, the chest x-ray showed a normal heart size, which is surprising given the cyanosis, but there were some other interesting features.
Like what?
Well, the apex of the heart, the tip, was broad and described as LV type, suggesting a prominent left ventricle.
So maybe the left side of the heart is working a bit harder than usual.
Possibly. And then there was a prominent right atrial border that seemed to merge with the SVC shadow.
Okay, and the pulmonary vasculature.
Oh, that was decreased, and the main pulmonary artery segment was actually absent.
Wow, so we're seeing signs of reduced blood flow to the lungs.
Exactly. And that makes sense with the cyanosis, right? If the blood isn't getting to the lungs to pick up oxygen.
Absolutely. Now, the fact that the heart isn't enlarged might mean that the problem isn't with the heart struggling to pump, but rather with a structural issue that's preventing that blood from getting to the lungs in the first place.
Right. It's like a roadblock somewhere along the way.
And the specific features of the heart, the prominent left ventricle and that right atrial border merging with the SVC, they suggest there might be some kind of right-to-left shunt happening at either the atrial or ventricular level.
A shunt meaning the blood is taking an abnormal shortcut.
Exactly. It's bypassing the lungs altogether.
Okay, case number 4. This is a 6-year-old child with mild cyanosis and respiratory distress.
Okay, so breathing problems are coming into play now.
Yeah, and the chest x-ray showed cardiomegaly and increased pulmonary arterial markings, so maybe some strain on the heart. But the most striking feature was this dilation of both the left and right innominate veins and the right superior vena cava.
Sounds like there might be some congestion in those veins.
Exactly, and it created this classic snowman or figure of 8 appearance on the x-ray.
Ah, the snowman sign. That's a very specific finding.
Yeah, and the superior mediastinum was also enlarged because of all that dilation.
Okay, so with the snowman sign and those symptoms, the mild cyanosis and respiratory distress is highly suggestive of total anomalous pulmonary venous return, or TAPVR.
TAPVR, meaning the pulmonary veins aren't draining into the left atrium like they should.
Right, they're going into the systemic venous system instead, usually through a persistent left superior vena cava.
And that's what causes that snowman shape.
Exactly, that backup of blood in those veins creates that distinctive figure on the x-ray.
It's like a traffic jam in the chest.
Very visually striking traffic jam.
Okay, on to case number 5. A 2-year-old child with clinical features of an ASD and PAH.
So a hole between the atria and high pressure in the pulmonary arteries.
Yeah, and the chest x-ray revealed something called an anomalous right pulmonary vein that was right next to and paralleling the right atrium.
Interesting. And did they mention anything else about its appearance?
Yeah, it was referred to as the scimitar sign.
Ah, the scimitar sign. That's a classic finding in scimitar syndrome.
So it's like a named landmark on the x-ray.
Exactly. And it's very specific to this particular condition which is a form of partial anomalous pulmonary venous connection.
Meaning that pulmonary vein isn't draining where it should be.
Right? Instead of going into the left atrium, it's draining into the inferior vena cava or the hepatic veins below the diaphragm.
And it gets its name because it looks like a curved sword on the X-ray.
Yeah, like a Turkish scimitar. That's a good way to remember it.
Wow, so even the shape of the vein can be a clue.
Absolutely. The human body is full of these little visual cues if you know what to look for.
Okay, last case. This one's a bit different. We're looking at a 6-month-old child with a history of stridor.
Stridor, so that high-pitched sound during breathing that often indicates some kind of airway obstruction.
Yeah, and instead of an X-ray this time, we have a 3D reconstruction of the aortic arch.
Okay, so we're getting a more detailed look at the structure of that main artery.
And the reconstruction showed a double aortic arch.
A double aortic arch. So instead of one arch, there are two.
Right, and they formed this incomplete vascular ring that was compressing the trachea.
Ah, so that explains the stridor. The ring is literally squeezing the airway.
Exactly, and the 3D reconstruction shows it perfectly.
It's a very clear anatomical picture of what's causing the problem.
Wow, so it's amazing how these different imaging techniques can give us so much information.
It's like having a window into the body.
Yeah.
You know, you can see things that you would never be able to see otherwise.
And by carefully observing those details, the size of the heart, the blood flow, the shadows, the specific signs,
We can start to put the pieces together and make those critical diagnoses.
and especially in pediatrics where early intervention can make such a difference.
Absolutely. These images are essential tools for guiding treatment and ensuring the best possible outcomes for these young patients.
It really makes you think about the future too, right? Like what kind of advancements in imaging technology are still to come?
I know it's exciting to think about how we might be able to see even more detail in the future, maybe with higher resolution or even completely new imaging methods.
And imagine if artificial intelligence could help us analyze these images in ways that we haven't even thought of yet.
The possibilities are endless, and who knows what kind of amazing discoveries are waiting to be made.
It's like we're just scratching the surface of what we can learn from medical imaging.
And it's all thanks to those fundamental observations, the same ones we've been talking about today.
So by paying close attention to those visual clues, we can continue to unlock the secrets of the human body and improve the lives of patients of all ages.
Absolutely. It's a powerful reminder that sometimes the most important answers are right there in front of our eyes.
We just have to know how to look for them.
And that's what makes this field so fascinating.
You know, it's like being a detective. You're always searching for those hidden clues.
Exactly. And every case is a new puzzle waiting to be solved.
Well, on that note, I think we've covered some incredible ground today. Thanks for sharing your insights.
My pleasure. It's always a great discussion.
And for our listeners out there, keep those eyes peeled and never stop questioning what you see because you never know what amazing discoveries you might make.
That's right. Keep exploring.
Yeah.
Keep learning and keep pushing the boundaries of what's possible in the world of medical imaging.
Until next time, happy sleuthing, everyone.
Happy sleuthing.